Hello everyone. Now we are going to discuss about very important topic, screening. So this is important for short notes as well as Viva, and very few times it will come for long also. And I am Dr. Anusha, Assistant Professor in the Department of Community Medicine. And we are going to discuss the screening topic under the following headings. First, we will discuss briefly about iceberg phenomenon, definition of screening, lead time, screening test versus diagnostic test, and types of screening, uses of screening, criteria for screening, and evaluation of screening test. We will just give brief introduction about iceberg phenomenon. We all know that disease in the community is compared to iceberg in the ocean. So this iceberg, only tip of the iceberg which is above the water line, that is only visible to the outside world or naked eye. So this compared to the disease, this floating tip is equal to the clinical cases which are having signs and symptoms. Because they are having signs and symptoms, they will go to physician and get checked up and get treated. But we are more concerned with this submerged portion of this iceberg. So like iceberg, it is below the waterline and it is not visible to outside. So disease in the community also, some cases like latent cases, inapparent cases, pre-symptomatic, undiagnosed cases, and carriers. So they will as they are not feeling the signs and symptoms, or only they are feeling mild symptoms, they will not go to physician and they will not get checked up. So this is submerged portion. So in screening also we are more concerned with this submerged portion of the iceberg. So to this hidden cases we will apply some test in screening and we will identify those cases. And we all know that exception for this iceberg phenomenon is measles, tetanus, rabies and rubella, which will not show iceberg phenomenon. Now we will see what is the definition of screening. So screening is a process of searching unidentified disease or defect or any condition of ill health by means of rapidly applied simple tests or examinations or other procedures in apparently healthy looking individuals. So in this definition you should remember some hook terms, like we are going to see unidentified disease, and what we are doing is we are applying rapid test, that too simple test, and on whom we are doing is apparently healthy looking individuals, we are applying this screening test. And you can remember, like, to the naked eye these persons are apparently healthy looking, but if we are seeing under magnifying glass in the form of screening test, and we are detecting that some people are having illness, like that you can remember. Now we will see a concept known as lead time. Lead time is the advantage gained by the screening concept. So if screening is not there, in the second diagram, second horizontal line, after the cancer onset, a person after having signs and symptoms, developing signs and symptoms, they will go to hospital and they will get checked up, and then only they will be diagnosed as having cancer after the appearance of signs and symptoms. So from that point of time till death, this time is known as perceived survival time. But after the concept of screening time, in the first horizontal line, if we see, we are detecting early, even before the appearance of signs and symptoms. So after first possible point of diagnosis only, we are detecting with help of screening test. So in the first horizontal line, if we see, first bar is cancer onset and second bar is cancer detected through screening. And so from that time, time since death is known as the same perceived survival time, but perceived survival time is increased because of screening technique. If screening technique is not there, perceived survival time will be less, and with help of screening technique, perceived survival time is increased. So here we are gaining certain time, so this time is known as lead time. So the time which is gained with help of screening is known as lead time. So this is the time between detection of disease through after the appearance of signs and symptoms, and even before the appearance of signs and symptoms, which is first possible point of diagnosis. So this is lead time. And to repeat again, this lead time is the time between the detection of disease based on the screening test and usual time of diagnosis after the appearance of signs and symptoms. So because we are detecting it early in the natural history or early in the pathogenesis, we can change the outcome, we can improve the prognosis of the disease, and uh, we can improve the survival, as we said. So but this lead time will be different for different diseases and different persons, it will be differ. And if we are having short lead times, sensitivity of the test will be less, and if after we conduct any screening camp, that will be of low use, less use, if we are having short lead time. But if we are having long lead time, so there will be risk of over diagnosis. And these screening tests will differ from diagnostic test, and now we will see what is the difference between screening test and diagnostic test. This screening test will be applied on apparently healthy individuals, as we discussed in the definition, and diagnostic test will be applied onto sick or ill individuals who are having signs and symptoms of particular disease. And the screening test will be applied to groups, where in diagnostic test will be applied to single patient. So the screening test, for example, if we are conducting any screening campaign in particular village, so the screening test will be applied to group of people who are living in that village. But diagnostic test means, so the persons who are having signs and symptoms of disease, they will come to physician, and they will be checked out, and then diagnostic test will be applied onto that particular single individual or patient. And screening test, how we will interpret results means, these results are arbitrary and final. Say for example, if we are keeping the criteria for screening test like fasting blood sugar of more than 120 to 126 is having diabetes, or screening test positive, then if how many people are getting fps more than 126, we will tell that the screening test is positive. But for diagnostic test, how we will interpret results means, the diagnosis is not final. If for example fbs is coming as more than 126, again they will do hba1c, again they will do postprandial blood sugar, like that. They will keep on applying test until final diagnosis. And the screening result will based on only one criteria cutoff, as we discussed, as fps more than 126. And this diagnostic test will depend, like they will evaluate what are the signs and symptoms of that patient and lab findings. So all these they will think, and they will decide as that person is having a disease or not. And the screening tests are less accurate and diagnostic tests are more accurate. And screening test, because we are keeping only one criteria, these are less expensive, but diagnostic tests are more expensive. And the screening test is not basis for the treatment. If any person screening test is positive means, they will be sent for diagnostic test, so it is not basis for the treatment, but diagnostic test is based for the treatment. And screening test in initiative will come from investigator or the researcher, not from people. But diagnostic test initiative will come from the patient. This patient only will go to doctor, and they will tell the signs and symptoms, and then only the doctor will advise some diagnostic test. So the initiative will come from the patient. And here one more concept known as gold standard test is also there. So difference between diagnostic test and gold standard test is, gold standard test is the diagnostic test with highest sensitivity and specificity. Say for example, in myocardial infarction, the diagnostic test is ECG findings along with tropi trop T. So with that they can diagnose that a person is having MI. But gold standard test, which is having highest sensitivity and specificity, is after patient death, after cardiac biopsy, if it is proved that that myocardial infarction is there in the cardiac muscles, then only we can 100% confirmly say that the patient had MI. So the diagnostic test is different, and gold standard test is cardiac biopsy in case of MI. Now we will see what is the conceptual framework. Nothing but if screening is positive, what we will do next. So we are applying this screening test on particular population. So in that population, if screening test is negative, okay. And if screening test is positive, then they will be advised to go up for diagnostic test. So after the diagnostic test comes negative, then disease is absent. But if diagnostic test comes as positive, then disease is present in those population. So if disease is present, as diagnostic test is basis for the treatment, they will be advised with particular treatment depending upon the disease. And now we will see what are the different types of screening. There are three different types of screening. One is mass screening, second one is high risk or selective or targeted screening, third is multiphasic screening. So this mass screening, as the name suggests, it will be applied for mass population. Mass means more number of people. So conducted for all population or subsection of the population. And high risk screening means, so this is the screening test applied for only high risk population or high risk group. And how we are telling that this population is high risk means, based on the epidemiological studies and research findings, we will keep some criteria. If they are fitting into that high risk category, then only we will apply this screening test among them. And multiphasic screening means, as the name suggests, multi, we are not applying single test, we are applying two or more tests. So application of two or more screening tests in combination to a larger number of people at a single time. That means at a time we are applying more than one screening test. So we will see example for mass screening. For example, if we want to screen for tuberculosis among all adults, so without keeping any criteria, we will screen all the adult population. For example, if we want to screen TB in Varangal, so we will screen all the adult population for TB. So this is mass screening. And high risk screening means, as I said, we will keep some high risk categories, then only if they are fitting into this high risk category, then only we will screen. So in the same example for TB, we will not screen all the adults who are residing in Warangal, but we will only screen uh, adult people who are living in slums, who are living in overcrowded homes, who are having contact with the TB patients either in the workplace or in the home, or people living with HIV. Only like this high risk categories we will keep, and only those population fitting into this high risk category, them only we will screen for TB in the second high risk screening group. And the third, multiphasic screening means, as we said, we are not applying single test. So along with questionnaire, we will do clinical examination like head to toe examination, and anthropometry like height, weight, BMI, and blood test, urine test, lung function test, audiometry, and even visual acuity. So like this, more than or equal to two screening test we will apply at a point of time. And what is the problem with this mass screening is, as we are applying it on more whole population or subset of population, it is more time consuming and resource will be wasted. But high risk screening means, as we are concentrated on a high risk category only, resources will be better utilized and less time consuming compared to mass screening, because we are including only high risk people. And multiphasic screening also, as it is including many screening tests, it will increase the cost of screening, and it will increase more number of healthcare personnel will be utilized for this with less observable benefit. Till now we have seen three different types of screening. And what is the use of screening? So now we will see uses of screening. So first use is for case detection. So this is also known as prescriptive screening. So case detection means to identify unrecognized disease, and this is for the benefit of patients, and it will not arise from patient request, but it will arise from investigators initiation. So it is initiated by medical or public health personnel. And this will fit correctly into screening definition, as we are applying on apparently healthy population, and the initiation is arising from investigator, not from the public. But here the benefit is for patient only. With this screening, if they are detected early, then prognosis will be improved, like case detection of breast cancer with help of mammography, pap smear, cervical cancer, deafness in children, in RBSK, diabetes, iron deficiency, anemia. And second use for the screening is control of disease or prospective screening. So this is not for the patient own benefit, this is for the benefit of others. How means, if a person from another country, so is coming with some signs and symptoms of COVID, and in airport or in port itself we are screening them with help of screening test. Suppose if they are screened positive for COVID, so we will keep them isolated for 14 days, as we have seen during COVID time. So how this will be useful means, it is not only benefit the person who had COVID, but it will also benefit that if the person comes to this India, because of that person so many people will get infected, so we prevented that also. So like that, this prospective screening is for the benefit of others also, and it also leads to early diagnosis, effective treatment, and reduce in the disease spread. Because of that person we are preventing the spread to others, and it will also decrease mortality burden. So example, screening of immigrants for TB, syphilis, COVID. And third use is research purpose. As a part of research in terms of case control studies, randomized control trials, or cohort studies. So like this, epidemiological studies we are doing. Why means to know the natural history of disease, to know deep about the disease which we don't know properly, and we should inform the participants priorly itself that we are doing it for research purpose, and because of this no treatment will be given, like that we should inform priorly. And examples like to know the natural history of lung cancer, hypertension, like that, to know in depth about any disease we can use this screening. And fourth use is for educational opportunities, like to create awareness in the public or to educate health professionals. Say for example, we selected some area in urban, so in the town we have selected one area, and in that area we have screened many people. We kept some criteria and we screened people for diabetes. So after screening, for example, 20% of the population who screening came as positive for diabetes. So till that time those people did not think that this diabetes is increasing and we might also have diabetes, like that they did not think. But after screening test come as positive means, so they will also have awareness that this diabetes is increasing, and we are some people we know are also detected with diabetes, like that they will understand. So this will create awareness in the public, and educates health professional about the disease burden in different places. Example, diabetes mass screening, as we discussed. And now we will see what are the criteria for screening test. So screening criteria will be for selecting the disease and for selecting the screening test to be applied. So first we will see what are the criteria for disease. So this disease should be a important public health problem. So majority of the population are suffering with this problem, then only we will select. Or if we select the minor problem which is not of more public health importance and we invest resources, it will be of waste. So it must be a important public health problem. And we about the disease we should know pathogenesis, and we should understand the pathogenesis, then only we can do screening. And third is availability of tool to recognize the early stages. So as we discussed in the lead time, after first possible point of diagnosis there should be an test to detect. If there is any test to detect, then only we can screen the disease, otherwise we cannot screen. And other criteria is availability of a tool for confirmation and appropriate treatment. So if the screening test is available, but after screening test as coming as positive, there should be a diagnostic test to confirm the disease, then only this screening test is of use, otherwise no. So there should be a test to confirm, and there should be appropriate treatment. If appropriate treatment is also not there, what we will do after screening positive? because we are not giving any treatment and we are not decreasing any disease burden. And another criteria is evidence that early detection reduces the morbidity and mortality. So with early detection, if outcome is changing, if survival rate is improving, if prognosis is improving, so like that evidence is there, then only we can select the disease for screening. And other criteria is agreed on policy on whom and when, what levels to treat. That means treatment guidelines should be there, and expected benefits are cost effective. So with the resources we are investing in terms of money, manpower and time, so it should be effective, cost effective. So with this, some use to should be there to the population, so it should be cost effective. So these are the criteria for selecting the disease. And now we will discuss about criteria for selecting the screening test. So there are three criteria to select any test to be a screening test: acceptability, consistency, and third one is validity. Acceptability means, so this test should be acceptable to the persons whom we are screening. That means, say for example, so screening tests which are including outside examination, head to toe examination, anthropometry, oral questionnaire, so they will be accepted more compared to the invasive tests like drawing blood, like that. So this tested to be acceptable. And the second criteria is consistency or repeatability or reproducibility. That means this particular screening test, if we are repeating multiple times, say for example, if we are repeating 5 times, so majority of the times it should give same result instead of different result. So that is consistency or repeatability. And third one is validity. Validity means result should be accurate. Accurate means it should be near to the reality, and it should distinguish the diseased people and non-diseased people correctly. So then only we can select that particular test as screening test. So acceptability, consistency and validity, so these are the three criteria which we will see before selecting a test for screening test. As we discussed, reliability is ability of a test to give the same results if repeated multiple times, keeping the other factors same. But there are some factors which affect the consistency. They are intra-observer variation, inter-observer variation, biological variation, errors of tool or method. Intra-observer variation means if the single observer or investigator giving different results on different observations, then we will call it as intra-observer variation. Say for example, the same investigator or observer measuring BP morning, afternoon, night. 3 times he is measuring, but he is giving different record. Say for example, systolic BP is 120 in the morning, 130 in the afternoon and 140 in the evening. Like that, he is giving different observation in different times. So that is intra-observer variation. And how can we minimize this intra-observer variation is by taking average of those three measurings. And the second one is inter-observer variation. Inter-observer variation means there is variation between different observers, observer A, observer B. If we are giving the same X-ray to different observer A and observer B, then they are giving different results. Observer A is telling that this X-ray is positive for TB, and observer B is telling that this X-ray is negative for TB. So like that, this is inter-observer variation. And the third one is biological variation. Biological variation means in the person, in the person only there is changing. So as we discussed in the first example of BP measurement in the morning, afternoon, evening, this observer is measuring correctly only, but because of variation, biological variation in the subject or patient, because of that we are getting different results. So that is biological variation. And fourth one is errors of tool or method. So the method we are using is wrong, or the instrument if it is not working properly, this errors of tool will come. So these are the factors affecting consistency. And about consistency and reliability concern, so there are four different scenarios. There are four different possibilities. So all these four means, first one is if we are aiming multiple times, so we are hitting different places in different times, then it is not valid and not reliable. And in the second one, if we are throwing and if it is some three are near to the center and rest all far from the center, that is far from the reality or actual reading. So this is valid but not reliable. Not reliable means different times different reading is coming. And the third is multiple times it is at the same points but it is away from the center, away from the actual reading. So this is not valid but it is reliable. And the fourth scenario is it is near the center and multiple times it is hitting the center. So it is both valid and it is both reliable. So this fourth scenario is known as Robin Hood scenario. And now we will see for any given screening test what is true positive, what is false positive, what is true negative, and what is false negative. And every time the disease should be given in the columns and test or risk factor should be drawn in the rows. So disease in the column and risk factor or test in the rows. So in the first column the patient has the disease and second column is the patient who is not having the disease, and first row is positive test result and second thing is negative test result. And in the first scenario, true positive means the patient is having the disease and the screening test is telling that he is having disease. Screening test is positive and the patient is having disease. So this is true positive. And the second one is false positive. False positive means the patient is not having disease but the screening test is telling that he is having disease. So that is false positive. So this test is telling falsely that the person is having disease. And third scenario is false negative. False negative means the person is having the disease but the test result is negative. Even though the person is having the particular disease, this test is falsely giving negative result. So false negative. And the fourth scenario is true negative. True negative means the person is not having disease and this test is also giving negative results. So the person is not having disease and test is also telling he is not having disease. So these are the four scenarios. And now we will talk about third criteria of screening test, which is validity. So validity means it is also known as accuracy, and it is the ability of a screening test to measure what it is supposed to measure. This is nothing but if we want to detect any disease, this screening test should differentiate between those people with disease and without disease. It should be able to differentiate. So that is validity. If a test which is having 100% validity means it will not give any false positives and it will not give any false negatives. It will only give true positives and true negatives if a test is having 100% validity. And what is the problem with this false positives means? A false positive means he is not having disease but the screening test is telling that he is having disease. So because of this, this person again will go to diagnostic test. Like that, utilization of healthcare resources will be there, which is of no use. And unnecessarily the person feel anxiety and inconvenience to the person who tested positive for screening test. And there will be health risk due to additional unnecessary diagnostic test like radiation exposure like x-ray. And what are the problems with false negatives? False negative means the person is not having disease, the person is having disease but this test is telling that the person is not having disease. Even though he is having disease, it is telling he is not having any disease. So because of this, the person will think that he is free from disease and he will not undergo diagnostic test and he will not use any medication and the disease will progress. And delayed medical attention increased disease transmission in the population because of that person. And now we will see evaluation of screening test. That means if any screening test is given, how can we tell that this test is good or not? So with help of sensitivity, specificity, positive predictive value and negative predictive value, we can tell the screening test is good or not. So sensitivity is also known as true positive rate. So sensitivity is nothing but ability of a test to identify those with the disease. That means if 100 people are having disease, at least it is identifying 90, 95, 98 people with the disease. So it is identifying more number of people with the disease. So that is sensitivity. And proportion of individuals with disease that have positive result. And how can we tell with help of formula means in the denominator people with the disease. People with the disease means true positives plus false negatives. And in the numerator, true positives. So the test identified those as having diseases true positives. So true positives by true positives plus false negatives. So this is sensitivity. It is also known as A by A plus C. And second thing is specificity. Specificity, we will also call it as TNR, true negative rate. So specificity is ability of a test to identify those without disease. That means this test is giving negative result for more number of people without disease. So true negative rate. So this is proportion of individuals without disease that have negative test results. So in the denominator, the people who are not having disease. Not having disease means true negative plus false positive, and in the numerator this test identified as having negative. So true negatives by true negatives plus false positives. We can also write like D by B plus D. And third one is accuracy. Accuracy means sensitivity plus specificity. Ability of a test to give all correct results. So proportion of true results. So all results means true positives, false positives, true negatives, false negatives. And in the numerator, true positives plus true negatives. Correct results. These two are correct results. So accuracy is sensitivity plus specificity. And now we will see what is positive predictive value and negative predictive value. So positive predictive value means ability of a test to predict the disease among those who test positives. That means in the denominator, all the people who tested positive for the screening test. That is nothing but true positives plus false positive. And in the numerator, those who have the disease. That is true positives. So ability of a test to predict the disease among those who test positive, and it helps clinicians to understand the probability of the test positive patient actually has the disease. This is nothing but if a positive test report is given to you. So in that positive test results, how much percentage you can tell that this person is having disease. How means this can be a true positive or this can be a false positive. So depending upon the positive predictive value of the screening test, we can tell to what extent this report is correct. And negative predictive value means ability of a test to predict non-disease among those who tested negative. So same like in the denominator, all the negatives, true negatives plus false negatives, and in the numerator, true negatives. So among all the negative, how many true negatives it is detecting. So this is also useful to detect the clinicians. So if a person is coming to you with a negative test result, so depending upon the negative predictive value of the test, to what extent chances will be there to be non-diseased, depending upon the negative predictive value of the test. Say for example, negative predictive value of the test is 95. So there is 5% chance that this person will be having disease, and 95% chance that this person is not having disease. So like that. And here we will see one example. So there are some people who screened for depression, and to that test which has been applied, sensitivity was 90%, specificity was 80%, positive predictive value is 47.4%, and negative predictive value is 97.6%. So sensitivity 90% means this particular test for depression will identify 90% of the diseased depressed persons correctly. That means 10% it will give false negatives. So it will leave 10 depressed persons as false negatives. Sensitivity 90% means, and specificity 80% means 80% it will identify correctly as non-diseased, but 20% it will give false positive result. So though 20% who are not having disease also, it will tell they are having disease. And positive predictive value of 47.4 means among those tested positive for depression with this particular screening test, only 47.4% are having actually depression. So rest all false results. And negative predictive value of 97.6% means among all the negative reports from this particular screening test, 97, nearly 98% negative results are correct, but remaining 2% negative results are false. So like that, how to interpret one report with help of positive predictive value and negative predictive value we should know. And the last thing is yield of a test. Yield is the number of cases detected through screening. Say for example, if we are conducting a screening campaign in a particular village, so with help of that screening campaign, how many cases we are detecting is the yield. So it is the amount of unrecognized disease diagnosed as a result of screening program. So this yield will depend upon disease prevalence in the community. So if there is if the prevalence of disease is more in that village, then only we can identify the deceased person. If they are not suffering from the diseases, how can we detect that they are suffering from the disease? So if those population, most of the people are suffering from the disease, then only we can detect with help of screening test. So if the disease prevalence is good and whatever the screening test we are applying, its sensitivity and specificity is good, then positive predictive value will be more. So if positive predictive value is more, then yield of the test will be good. So yield is estimated directly from the positive predictive value. And this positive predictive value will depend upon the disease prevalence. So most effective way to increase the yield of the screening program is we should select the high prevalence area, and we should select the high prevalence populations, and we should select the high risk individuals. Then only we can increase the positive predictive value and we can increase the yield of the test. And this is for today. Thank you.